Bismillahirrahmanirrahim. In the previous lecture, we discussed nephrotic syndrome, and we discussed that nephrotic syndrome is a clinico-pathologic presentation of some underlying glomerular disease. There are many diseases that can give rise and present as nephrotic syndrome, and today we will discuss various diseases that cause nephrotic syndrome, and we will discuss in today's lecture the minimal change disease, which is also known as nil disease because there is a very minimum damage in the glomerulus that give rise to proteinuria. And we will also discuss focal segmental glomerulosclerosis, in which the glomerulosclerosis occur in some glomeruli and particularly in the segments in some segment of the glomerulus. Minimal change disease is more common in children, while focal segmental glomerulosclerosis is mostly common in adults. However, it can also occur in children. For our convenience, we classify kidney diseases into those diseases that affect the glomeruli. Mostly, the diseases that affect the glomeruli in the form of glomerulonephritis, they are often immunologically mediated. In addition to the diseases that affect the glomeruli, there are certain diseases that affect the tubules and the interstitium. And mostly the diseases that affect the tubules and interstitium are caused by toxic agents or by infections. In addition to the glomeruli, tubules, and interstitium, there are certain diseases that particularly affect the blood vessels in the kidney. In the previous lecture, we discussed nephrotic syndrome, and we discussed that a glomerular disease that damages the glomerular basement membrane leads to increased permeability, particularly the proteins. If only albumin is filtered into the filtrate that will then pass in the urine, then we say this is selective proteinuria. But if in addition to albumin other proteins are also filtered, then this will be non-selective proteinuria. So glomerular syndrome, the nephrotic syndrome, is a clinico-pathologic presentation which is characterized by massive proteinuria. By that we mean that more than 3.5 grams of albumin are excreted in urine per day, and the proteinuria and excretion of albumin in urine will lead to hypoalbuminemia. And we know that the albumin is the major protein present in the blood for maintaining the colloidal osmotic pressure and holding the fluid in the blood. When there is a fall in albumin, or if there is hypoalbuminemia, particularly if it is less than 3 grams per deciliter, what will happen that at the venular end of the capillary, the colloidal osmotic pressure that will pull the fluid back into the blood will be decreased, and fluid will stay out in the extravascular tissue and giving rise to the edema. Additionally, in nephrotic syndrome, what happens that the hypoproteinemia stimulate the liver to produce more proteins. This is a compensatory response of the liver. But in addition to producing albumin, the liver also starts producing other proteins, particularly the lipoproteins, and this will lead to hyperlipidemia, increased level of the lipids or lipoproteins in the blood. It is also said that proteinuria in nephrotic syndrome leads to loss of those proteins that inhibit lipid or lipoprotein synthesis by the liver. So the increase in the synthesis of uh, lipoproteins by the liver and the loss of those proteins that inhibit lipoprotein synthesis leads to elevated level of the lipids or lipoproteins in the blood, and this condition is known as the hyperlipidemia. If the glomeruli or the filtration barrier is damaged, the hyperlipidemia will lead to lipiduria, in which the lipids are excreted in the urine. Before we go to discuss diseases that affect the glomerulus, let us have a brief review of the glomerular basement membrane, because this is the barrier through which the proteins will pass before they appear in the filtrate and pass in the urine. Normally, this glomerular basement membrane does not allow proteins and red blood cells to pass through. But however, if it becomes damaged, then proteins and in severe damage, even cells, they will pass this barrier and will enter into the filtrate and will appear in urine. Normally, only small molecules like sodium and water, they are filtered. But proteins and cells, they are not filtered through the glomerular basement membrane. If we have a look at the glomerular basement membrane, or GBM, we see that on the inner side there is the uh, endothelial lining, and the endothelial cells that line the glomerular capillary endothelium, they have fenestrations and they are known as the fenestrated endothelium. Then on the outer side of the fenestrated endothelium, there is the glomerular basement membrane, which is mainly composed of type 4 collagen and other proteins. Now, outside the glomerular basement membrane, there is the epithelial layer of the podocytes, which form the visceral epithelium of the filtration barrier. And these podocytes, they have their food processes and they wrap around the glomerular basement membrane, and the food processes, they interdigitate, and in between the interdigitated food processes there are filtration slits. So there are two barriers in the glomerular basement membrane. One barrier is that of size of the fenestration and size of the slit filtration slits in the visceral epithelial or podocyte layer, and the other barrier is the charge. Normally the whole basement membrane is negatively charged and it will repel the negatively charged proteins and molecules. However, as compared to the ability of the glomerular basement membrane to repel anions which are negatively charged, the positively charged ions are cations, they can easily pass through the filtration barrier, and in the disease that we are just going to discuss, known as the minimal change disease, there is no problem in the glomerular basement membrane, but the damage to the visceral epithelial layer or podocytes results in the loss of the negative charge, and as a result, albumin, which is negatively charged, is not more repelled, and it will appear in the glomerular filtrate. We know that minor injury to the filtration barrier will result in leakage of proteins, particularly albumin. And if only albumin is allowed to pass through the filtration barrier into the filtrate and into the urine, and other proteins are not allowed, then we say this is the selective proteinuria. But if the injury is a little more severe, then along with albumin, other proteins also will pass through the filtration barrier. And now we say this is non-selective proteinuria. In non-selective proteinuria, in addition to albumin, other proteins are also passed. But it is important to remember that if the excretion or loss of albumin is less than 3.5 grams per day, then we say that this is the subnephrotic range. It will not give rise to nephrotic syndrome. And we say this is the subnephrotic range proteinuria. However, if the injury becomes more severe, then what happens? That the loss of albumin is more than 3.5 grams per day. And now we say that this is the nephrotic range proteinuria. It may be selective, only albumin may be filtered, or it may be non-selective, where other proteins along with albumin are also lost in the urine. Now, proteinuria where more than 3.5 grams of albumin is lost per day, it will lead to hypoproteinemia, fall in colloidal osmotic pressure, and edema, which will particularly appear in the periorbital region around the eyes, where the connective tissue is comparatively loose, and as we said that the compensatory increase in the protein synthesis by the liver, there will be increased production of lipoproteins along with albumin, and increased production of the lipoproteins will give rise to hyperlipidemia, and some lipids are also filtered through the filtration barrier, which will give rise to the lipiduria. Now, the common glomerular diseases that allow proteins and other contents of the blood to get filtered into the glomerular filtrate and causing nephrotic syndrome. These causes are divided into those causes that primarily affect the glomeruli and the cause lie within the kidney. And sometimes the glomerular act as a bystander, innocent bystander. The disease and its etiology is somewhere else, but is an association of a systemic disease, the glomeruli are damaged. So, primary glomerular diseases that give rise to nephrotic syndrome include minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis, and membranoproliferative glomerulonephritis. Systemic diseases that are associated with damage to the secondary damage to the glomeruli and nephrotic syndrome. The most common are the diabetes mellitus, systemic lupus erythematosus, various infections, for example, hepatitis B virus infection, human immunodeficiency virus infection, and diseases like malaria and syphilis, and conditions like amyloidosis and sometimes malignancy. Now, in minimal change disease, The exact etiology is unknown, but it is believed that the T cells, which is the cell-mediated part of the immune system, these circulating T cells release certain factors in the form of cytokines. And these cytokines are believed to affect the visceral epithelial layer of the glomerular barrier, particularly the food processes of the podocytes. And as a result of the damage caused by the cytokines on the food processes of the podocytes, which are cells of the visceral epithelial layer, these food processes and podocytes, they undergo effacement. This is normal food process, and this is the food process after effacement. So what happens that the effacement of the food processes of the podocytes results in loss of the negative charge. And we know that there are two barriers. One is the size barrier and other is the charge barrier. So the podocytes and its food processes are negatively charged, and normally they repel negatively charged proteins like albumin. But once in minimal change disease, this effacement of the podocyte food processes results in the loss of the negative charge. And this loss of negative charge allows the negatively charged proteins like albumin to be excreted in glomerular filtrate, and they will appear in urine. And as a result, the proteinuria will lead to hypoproteinemia, and ultimately it will lead to the nephrotic syndrome. The exact cause of the minimal change disease is unknown, but it is said that certain cytokines and factors that are released by the T lymphocytes cause damage to the podocytes, and these podocyte processes undergo effacement. Under the light microscope, in minimal change disease, the appearance of the glomerulus is completely normal. However, if we see the glomerulus under the electron microscope, we will see uniform and diffuse effacement of the food processes of the podocytes. Here we can see normal food processes of the podocytes and damage to the food processes of the uh, podocytes, which will give rise to the effacement. So it is important to note that in minimal change disease, only albumin is allowed to filter. Other proteins, immunoglobulins, and large proteins and cells, they are not allowed to pass the filtration barrier. And this loss of the albumin, the negatively charged protein, is mainly associated with the loss of the charge barrier, loss of the negative charge. Minimal change disease is also known as the nil disease, and it can be easily treated because the treatment is mainly to treat the disease with corticosteroids, and the response to the corticosteroids is very effective. And minimal change disease, which is the most frequent cause of nephrotic syndrome in children at the age of 1 to 7 years, and 90% of the children, they respond to treatment with corticosteroids. And in those of the 10% cases, they do not respond to corticosteroids. There may be coexisting problems, other problems. Now in this picture, we can see that this is the normal basement membrane, and the visceral epithelial cells are podocytes and their food processes. But in minimal change disease, what happens that effacement of the food processes occurs, and the food processes are lost, and the loss of the negative charge which is present on the podocytes then allow the negatively charged albumin to get filtered into the glomerular filtrate. Now the second disease, which is a little more severe than minimal change disease, is known as the focal segmental glomerulosclerosis. The focal segmental glomerulosclerosis is a severe disease as compared to minimal change disease, and in this disease what happens that the proteins and lipids, in addition to they are excreted in the urine and filtrate, they get deposited in the Bowman capsule and uh, in the glomerulus and form hyaline masses, which later on may undergo sclerosis. And what happens in glomerulosclerosis, that the normal glomerular tissue is replaced by scar tissue formation. Focal segmental means, by focal we mean that only some glomeruli are affected, not all the glomeruli. Segmental, by segmental we mean that only a portion of the glomerulus is affected. So there is scar tissue formations which is segmental and occur in a segment of the glomerulus and in some glomeruli, not all glomeruli. And it will give rise to loss of proteins in the urine, and the patient will present with nephrotic syndrome. And focal segmental glomerulosclerosis or FSGS is more common in adults. So the deposition of hyaline mass is known as the hyalinosis, is that entrapment of the plasma proteins and lipids in the glomerular space where normally glomerular filtrate should collect. It will disturb the function of the glomerulus and will form hyaline masses known as the hyalinosis, and later on these hyaline masses may undergo sclerosis and formation of scar tissue occurs, replacing the normal glomerular tissue, and this will lead to the loss of function of the nephron. There is damage to the podocytes, food processes, and which lead to increased permeability. And initially, in focal segmental glomerulosclerosis, only damage to the podocyte can be noted. However, this initiating effect when starts give rise to is progressive, and there will be entrapment of the plasma proteins and lipids in the glomerular space, which later on becomes sclerosed, leading to glomerulosclerosis and loss of nephron. In this picture, we can see that some glomeruli are affected while some are not. Therefore, we say this is focal disease, affecting some glomeruli but not all glomeruli. And within the glomerulus, a segment of the glomerular capillary is affected, not the whole tuft or the whole length of the capillary. And by glomerulosclerosis, we mean that the formation of scar tissue in the glomeruli. So what happens in FSGS, that the affected glomeruli, they allow proteins to filter into the tubules, and this the patient will present with nephrotic syndrome. But additionally to the proteins and lipids filtered that pass in the urine, there is accumulation of the filtered proteins and lipids. In other words, we can say that they are trapped here in the glomerular space. And they will form an acellular hyaline mass known as the hyalinosis, and this mass later on may undergo sclerosis known as the glomerulosclerosis, and this will lead to the loss of the nephron function. Initially, there is hyalinosis. Proteins and lipids, they are trapped. In addition to those that pass in the urine, some are trapped here in the glomerulus and form acellular hyaline masses, and these acellular hyaline masses that and this hyalinosis, they later on may undergo sclerosis known as the glomerulosclerosis. Now, mostly the cause of the FSGS is idiopathic. There may be some genetic error, but whatsoever, we are unable to identify the cause. And this is the primary FSGS. And it is idiopathic because we don't know the cause. However, in secondary FSGS, which occurs in association with certain systemic diseases, the major ones are the human immunodeficiency virus, or heroin abuse nephropathy, and other forms of glomerulonephritis may be associated. For example, IgA nephropathy may be associated with FSGS, and sometimes the maladaptation to nephron loss. By maladaptation to nephron loss, we mean that when some of the glomeruli in the kidney are damaged, what happens that there is compensatory hyperplasia in the and hypertrophy in the rest of the healthy nephrons to maintain the filtration, glomerular filtration rate. But however, this extra load in the form of hypertrophy and hyperplasia on the healthy nephrons, ultimately there will be increased intraglomerular pressure, increased capillary pressure or capillary hypertension, and ultimately these and gradually these healthy nephrons also undergo sclerosis. And as a result, when more than 25%, when more than 75% loss of nephrons occurs, the patient will progress to end-stage renal failure. FSGS may also be associated with certain congenital or inherited conditions. But whatsoever is primary or secondary in FSGS, there is deposition of hyaline masses and increased mesangial matrix. The mesangial cells secrete excess mesangial matrix. And basically, the starting problem in the FSGS is the loss of or effacement of the food processes, followed by the hyalinosis, followed by the glomerulosclerosis, and ultimately the disease which initially occurs focally in a few glomeruli, then more and more glomeruli will become affected, and here we say that there will be advanced global sclerosis. And when more than 75% of the nephrons are damaged, the patient will now progress to chronic kidney disease and end-stage renal failure. Morphologically, the glomeruli that are affected by the FSGS, they show and exhibit increased mesangial matrix. The glomerular capillaries here are obliterated and obstructed lumina and deposition of hyaline masses known as the hyalinosis in plus the various lipid droplets may be less or more. In the affected glomeruli, immunofluorescence microscopy, in which we label an antibody with a fluorescent dye, and then we see the reaction of the antibody with the antigen under the microscope. In FSGS, we will see non-specific trapping of the immunoglobulins, usually immunoglobulin M, and complements in the area of hyalinosis. However, it is not clear that either the immune mechanism play some specific role in FSGS or not. However, but therefore we say that there is non-specific trapping of the immunoglobulins in the mass of hyalinosis and glomerulosclerosis. On electron microscopy, we can see just like in minimal change disease, there is loss and effacement of the food processes of the podocytes. And some researchers believe that FSGS may be a continuation of the minimal change disease. Initially, there will be minimal change disease, and then it will evolve into FSGS. But some pathologists say that the two diseases, minimal change disease and focal segmental glomerulosclerosis, are entirely different pathological states and have different mechanisms and different causes. Ultimately, progression of the disease will lead to global sclerosis of the glomeruli, which will lead to pronounced tubular atrophy and fibrosis that occurs in the kidney interstitium, leading to interstitial fibrosis, and the outcome will be in the form of end-stage renal disease. In this picture, we can see a normal glomerulus, and here the porous capillaries allow waste products to pass out into the urinary space, creating urine, and normally there is sufficient production of the urine and the urine output is enough. But in FSGS, what happens that a considerable portion of the glomerulus is damaged and there is sclerosis around the capillaries, and ultimately it will lead to decreased glomerular filtration rate, and the decreased GFR will lead to decreased urine output, which may lead to oliguria, and additionally the decreased GFR and decreased urine formation will lead to azotemia. Certain waste products like blood urea nitrogen and creatinine, they will get accumulated in the blood. In this picture we can see the hyaline tissue formation in the kidney, and there is a mass of scarred obliterated capillary lumen with the accumulation of matrix material that has replaced a portion of the glomerulus. In this slide we can see that there is after hyalinosis there is focal segmental sclerosis, and in this part of the glomerulus, the segmental sclerosis has replaced the normal tissue, while some saved and conserved architecture can be seen here. Diagnosis of FSGS is made by urine examination, urinalysis for blood, proteins, and cholesterol, and the diagnosis is confirmed by renal biopsy. But in renal biopsy, as compared to the minimal chain disease, where we don't see any abnormality, in FSGS we can see under light microscope the hyalinosis and segmental sclerosis. And under the electron microscope, we can see the effacement of the photocyte foot processes. And in the immunofluorescence technique, we will see non-specific focal deposits of immunoglobulin M and complement. The clinical picture of FSGS, that in children it is very important to differentiate this condition from minimal chain disease, because minimal chain disease shows a good response to corticosteroid treatment, and while FSGS, the response to the corticosteroid is inconsistent. And it is important to differentiate between the minimal chain disease and the FSGS. The incidence of hematuria and hypertension is higher than FSGS, and it is a more severe disease when we compare it with the minimal chain disease. And in minimal chain disease, there is selective proteinuria. Only albumin is lost. But in focal segmental glomerulosclerosis, the proteinuria is non-selective. In addition to albumin, other proteins are also lost. And the response of the minimal chain disease to the corticosteroid treatment is very effective, while in FSGS there is poor or inconsistent response. And 50% patients of the focal segmental glomerulosclerosis will progress to progressive loss of the nephrons, and ultimately more than 75% loss of the functional nephrons will lead to an end-stage kidney disease, mostly within 10 years of the diagnosis. And the response of the children and the prognosis of the disease in children is better than the adults. Thank you very much.